Good afternoon, everybody. This is Tim Handley. I'm the General Manager of the HSE's National Safeguarding Office. This afternoon, we're discussing the topic, no excuse for elder abuse. And I'm in conversation with Margaret Flynn. And I'll introduce Margaret in a moment. Today is part of a series of events happening on or around June 15th. Each year, World Elder Abuse Awareness Day falls on June 15th. It's a United Nations observed day. And our office is the national office for the HSE. We collect data, we publish reports, we undertake training, and we coordinate the work of our safeguarding teams around the country. So it's a very important day to highlight the issue of abuse of older persons, to, I suppose, mark that it's not just an issue here in Ireland, and we'll hear from some of Margaret's experiences and some of her knowledge and wisdom from the UK, but also internationally. We know how much COVID-19, the impact of the pandemic has made internationally. I'm wearing the purple ribbon today as a sign of solidarity for people, older people here in Ireland, but also right throughout the world. It has been a horrendous impact on some people's lives, their futures, their social context, their livelihoods, their pensions, their access to services. So I think it's intergenerational and international solidarity is needed now more than ever. So I'm delighted that Margaret, who's an old friend of our office and was over here in 2018 speaking to the social workers in the National Safeguarding Office. Margaret has an extensive bio. I'll just touch on a few areas of it. She's currently the chair of the Independent Safeguarding Board in Lancashire. I hope I pronounced that right. And previously the Safeguarding Board in Wales. She's joint editor of the Journal of Adult Protection with Bridget Penhill. Since chairing the Stephen Hoskin Serious Case Review, Margaret has chaired and written several reviews. She's addressed the deaths of adults with learning disabilities and of adults with mental health problems. These consider cruelty such as torture, sexual humiliation, coercion, theft and suicide, as well as murder and separately self-neglect. Margaret wrote the Winterburn View Hospital Serious Case Review with Vic Citarella, and I hope I've pronounced that right. In December 2013, Margaret was commissioned by the First Minister of Wales, Cameron Jones, to undertake a review of neglect of older persons living in care homes investigated in Operation Jasmine. I know Margaret has also had numerous research positions at a number of universities and writes for academic and practitioner audiences. And something I like particularly about Margaret's work is that she also writes for people who have limited literacy skills. So and I think that's fantastic that it's not just for the academics and the practitioners, but also the very people who we should be there to serve. So I'm delighted to have you this afternoon, Margaret. We'll be talking for about 40 to 50 minutes. It's a conversation. No excuse for elder abuse. I think it's indicative in the title of what our conversation is that there is no excuse, and we should always be mindful of that. But maybe I'll start a little bit at the beginning, Margaret, and maybe a little bit about your own story and your interest in safeguarding. But I suppose one question is, Margaret Flynn, there must be an Irish connection in the name.
Oh, there is. Of course there is, yes.
You might share that with us. There's an Irish audience here. You might share
and it's down to the potato famine, I'm afraid, and that's where my family came over from Ireland.
Okay, great. Like so many more of the immigrant community, and have contributed so well to the United Kingdom and right throughout the world. Margaret, what got you into the work of adult safeguarding? What brought you to this work and the work that you're championing? And you've been a fantastic champion for, I suppose, human rights of people and exposing and investigating where there's been serious failings. What brought you to that, Margaret?
I think it begins with my family and my earliest experience. I have a brother with a learning disability, and from that very early age was so conscious that he required some support, he required some prompts, and he certainly required protecting from people who might otherwise have bullied him, or indeed on occasions did bully him. So that was my early experience. And in fact, one of my enduring memories is of standing beside him as he was being teased in a playground. I just knew that it was wrong. I didn't like it, but I certainly didn't have the words to yell back at the bullies. I'm not suggesting, by the way, that there's anything saintly in my behaviour. It was just I knew that this was wrong, and that we had to look out for Peter. So that started. That certainly shaped my interest in and choices in terms of study and a subsequent career in academic research and thereafter.
Yeah. No, and I'm very struck reading some of the work that you've been involved in and the reviews that you've led, is that passion for justice. But I've also been struck, and we'll touch on some of the work you've done with serious case reviews around the person being at center, and not just the compassion for the people, but actually the people, their lives, their names, their histories of them as people, rather than just being subjects of review. So I think your own personal experience obviously been has given you that mission, and so thanks very much for sharing that piece about your own family and your brother. Can I ask you a little bit about your thoughts from the UK? We've come through a very difficult time emerging from COVID-19, and thinking about strategies that you might think about preventing abuse and monitoring abuse, particularly in nursing and residential care. What would your thoughts be around the approach and the strategy, both at a state level and maybe more at an operational level, for the prevention of abuse, and also the good systems of responding to abuse now that we're hopefully emerging with the vaccination program?
I think it would be asking some very reasonable questions at a state level, asking questions, okay, and during the worst of times when families were not allowed to visit their relatives, and I think there are some questions to be asked about that, but in the worst of times, I think it would have been quite reasonable to ask, and what are you doing instead? You're not receiving guests, you're not receiving visitors. So how are you looking out, and who is looking out for the people for whom you have a duty of care? Because as relatives, when we visit our loved ones, we want them to be okay. We want to see them. Because we know them, we know their bodies, and we can tell immediately when there's something wrong. So I want to know what equivalent is in place. I've been interested and troubled that the number of organisations campaigning for access to care homes, family members very willing to wear PPE equipment, very willing to be volunteers in homes, have struggled to make their case. And I think, what on earth is it that has prevented them from doing so? A great deal has been left to the discretion of homes, and I do understand if homes have had many deaths or many cases of COVID-19, but for those homes that haven't, and those homes that can trust known visitors who are very committed to their relatives, why can't they come in? Because typically relatives are concerned principally about their own relative. Also, they have eyes and ears. They see what's happening, and they can and do report things that shouldn't be happening.
And do you feel that
it's attention to the potential for errors and oversights, and that families are good at spotting?
Yeah, and you've highlighted there, I suppose, the protectiveness of the families, the eyes, the ears of the family, and they can be neighbours and friends as well. Do you feel that there's been quite a strong risk-averse situation balancing the public health measures and that kind of family psychosocial contact, as well as the protectiveness of it? Is that you're feeling?
Yes, that would be my view. And we know that prevention, one measure of prevention is to say confidently, yes, and we've got a really good recruitment policy. We can hand on heart say our staff are wonderful, and we can hand on heart say that we believe we work within the parameters of good policies, and we have good procedures. Okay, well, demonstrate that. Show us what's happening as a result of that. Now, that's not to suggest that homes haven't gone to the extra length.
Yeah, I was going to ask, are you aware of where there's been really good models of how homes have managed that serious difficulty of balancing public health and people being isolated by visitor restrictions?
Well, yes, indeed. I mean, some staff have undertaken to remain away from their own families so that they can continue to work and to support people, and also go to extraordinary lengths of, making sure, for example, that they can use their phones, because of course if people aren't accustomed to using technology, how bizarre is it to see a face on a telephone or on a small screen? And I think it has been heartwarming that some families it's been possible for some families to remain connected, but this in a very fraught period. Has been so much uncertainty and regrettably a lot of misinformation concerning the status of the pandemic.
Yeah, and do you have any messages around that kind of as we move to the next phase with vaccination and visitation restrictions being lifted? What measures are important that we learn from and we implement to, I suppose, strengthen systems that monitor such as visitation as being one? But have you had thoughts on that?
Yes, I think homes are as upfront as people's relatives have been. Some residents have declined in this dreadful period because they haven't been connected. They haven't been linked to their families and frequent visitors. And as a result of that, their lives have changed massively. And without the stimulus that arises from that, I think homes are very conscious of a shift. So I like to think that one very significant and important outcome of this is actually the role of people coming in, people greeting, people feeling that they're part of something else, part of a small community, a group of friends, whatever, and that matters enormously to all of us.
So more than a visitor, that interface of feeling involved and part of it, right?
Okay. Yes, I think so, because that's about valuing relations and relational practice. That's what we've got to do.
Well, thanks very much, Margaret. Some really important points there. If I could ask you, one of the debates, again, I suppose coming out of COVID, and we've had an expert panel report here, is consideration of future funding models and kind of continuum of housing right through to residential and nursing care. Have you had any thoughts in the UK, or is that debate strong in the UK as it is here in Ireland, that we should look at our models of how we fund care and have a continuum of care options for people and choice for people? Is there a similar debate in the UK?
I think there is, yes, partly because of the potential support ratio is going down. There's going to be many more older people than there are potentially people to provide support to the older population. And I think that's given rise to discussions about what it means for individuals who are in their own homes or are tenants, whatever, and how fit for the future their properties are. So I think there's a lot of discussion about future-proofing our own homes, tenancies, and also about looking to improve our housing stock. Now, I live in Wales, and I'm really quite interested that Wales has got a quality standard, and that's about ensuring that homes are suitable for existing and future residents and tenants. So that's the standard, and I think that's really quite significant. And I compare that, I'm afraid, unfortunately, with England's, where we've got a whole office block here. Thank God it's empty now. Now we can put some people in that home, and I think that is not about ensuring good standards that's suitable now or in the future.
Because I was struck, and we'll come on in a moment to talk about some of the work you've done in reviews, but on the in your review in search of accountability in the nursing homes in South Wales was the issue of choice. Had older people themselves with their families, and that is a huge issue here in Ireland, in that we have a statutory entitlement to around applying for nursing home care, but we don't have as yet one for home care provision. So is that a serious, significant issue from your experience? Is that
absolutely
the lack
yes.
of choice, the lack of meaningful choice?
Well, it's interesting, the lack of choice. Once families appreciate that perhaps more care is required for somebody than they're equal to managing without assistance, and the possibility of residential or nursing care comes into view, then very typically people are given lists of homes. You know, these are places you might want to look at. But how useful is that if you have no idea what constitutes a good home? And this is because those who are providing the lists are not allowed to say, well, you know, actually this is the best. They're told to look at the regulators' inspection reports. And again, you might ask, well, how relevant is that? If people are having having a very difficult time in that particular home, how relevant is that if people are being supported by staff with questionable relevant experience or even training? And that information isn't available. So people are very, very dependent on professionals.
Yeah.
And
are there ways to improve access to good quality information in a range of formats? So, you know, this whole area of informed choice, where we're hopefully next year in Ireland implementing the assisted decision making and the will and preference of the person, the assumption of capacity, that people are given information in a way that they understand, and that there isn't pressure or coercion around care choice, care provision. Are there good examples in the UK that you've come across where some authorities and care providers have taken initiatives in that way?
I think there are small scale examples, yes. I am currently the trustee of a charity, and although the charity supports people with learning disabilities in some of the rural parts of North Wales, the charity has also been asked, by the way, when you're visiting this person, we have somebody in that locality who is beginning to struggle with managing. The fact that they are in their 80s and have just been diagnosed with dementia is really interesting. That would not have happened years ago. So increasingly, our support workers are being invited to consider supporting people in their own homes.
Right. Okay.
And there are examples of that, I believe, in England as well. There are also examples of care homes and nursing homes themselves establishing themselves as something of a hub and being available to their immediate locality, not to hundreds of miles away.
So kind of a deinstitutionalization of care in a way.
That's right.
Yeah,
so it's not just people who are in the home, but it might be people coming in perhaps to have lunch because they've, you know, their skills in getting their own meals together has become compromised or whatever. So there are examples like that from the more open sort of service and from the more imaginative commissioners.
Sure, yeah.
But otherwise,
there are some international models.
Yes,
are they the minority in your experience?
They are. Yes, they are in the minority. And I think for too many people, it becomes a feared option moving into care. It's a transition that is not currently valued.
Right. Margaret, if we could come on to the area of kind of what I call the tolerance and acceptance of elder abuse, and again coming back to the title of our discussion today, No Excuse for Elder Abuse. One of the things that struck me about your review, In Search of Accountability, and particularly when you furiously questioned the Crown Prosecution Service and the police forces in South Wales and service providers and others, was the area of it wasn't seen as criminal. You know, the way if I walk out on the street today and someone assaults me, I'm here on the main street in Limerick today, I'll go straight to Henry Street Garda Station and I'll make a report of a crime, and I'll expect that they'll investigate me for being assaulted. Would you like to say a little bit about that? And what really struck me was that what informed that view about, you know, things that weren't seen because people were elderly or they were in care or they were marginalized, that being harmed, abused, and indeed assaulted. And we saw the horrendous, I mean, descriptions there around people with maltreated, pressure sores, malnutrition, dehydration, neglect. What do you think was behind that, Margaret? Why it wasn't seen as a serious crime?
I'm afraid it was pretty bleak. It was about profit. The GP owners of this portfolio of care homes they were concerned and driven by profit. Right. Profits were their priorities. Mm-hmm. And it's very difficult for non-GPs to challenge a GP who is saying, but older people develop pressure ulcers. Right. That's what happens. They're elderly, they become incontinent, so they urinate on ulcers, and then they become infected. What do you expect? Only in a much more angry tone than that. Mm-hmm. So I think that's part of the picture, but also, what else was there? That was the question. Yeah. Very typically, the residents had dementia, and though they had families who were extremely concerned about their relatives, it was very difficult for them to challenge one particular member of this couple, the man. It was very difficult to challenge him because he became so furious and started shouting. And most of us do not like adults who yell at us. Sure. And we resist contact with them. Some of them made complaints that didn't go anywhere. Some of them went to safeguarding. Safeguarding said, yes, this is indeed an example of institutional abuse, but no action was taken. Regulators sought to make change, but they were limited and compromised by the legislation to which they were working at the time. All of those factors came into play.
And to come back to the issue about, so other medics were compromised in or lacked an ability or were constrained around challenging the owner or because would other people from medical not have known that this was abuse or poor treatment and poor management and medically wasn't appropriate care? Would they have not known?
Because
yeah.
There was a traffic of these poor souls having to go to acute sector hospitals because their injuries were so extensive. And necessarily the medics in emergency departments and accident and emergency were appalled and horrified, as well as the nurses. And in fact, some of the relatives described meeting their relative in emergency departments and seeing for the first time the extent of the harm arising from these horrific pressure ulcers. However, their relatives were in their late 70s, 80s, and they died in hospital. That was not that unusual, that older people should die in hospital. So nobody was asking questions, there has to be an inquest now, that we really need an inquest because look at the estate of these injuries. And communication between the acute sector hospital and adult safeguarding, for example, really didn't exist. They took the fact that actually this is a home that clearly hasn't got much about it because these poor souls keep coming in. Nobody was saying, but surely, what about, the public purse, because it's costing a fortune to help people recover from these dreadful injuries, though they're being paid for in these care homes.
So even though complaints were made, issues arose, over time, systematic failures continued.
Oh, yes. And there were even TV programs about how dreadful their homes were. Yeah.
Wonder, we frozen there, Margaret? Are you able to hear me okay?
TV Wales. So even though it was well known, this persisted, and it is only truly in the last few months that the inquests, the main body of the inquests have come to a close, and one inquest is still ongoing.
And are you hopeful that governance and oversight will improve, Margaret? I mean, I'm interested in how systems of oversight by state bodies and commissioners and funders had such a long, significant failing.
Yes, yes, I am, because it was commissioned by the First Minister, and he talked about learning for the future. And once the report was produced, he also talked about it feeding into new legislation for the regulation, for the purposes of regulation. At the time said, we need to share this information around Wales. So it wasn't a case of, so we'll have a conference. There are 6 major areas Wales can be cut up into. And so we contributed, I say we, this was the relatives of people who had been harmed in the homes. We gave conferences in these 6 localities to audiences of professionals, sometimes up to 300-400 people. So there aren't very many professionals in Wales who do not know about Operation Jasmine.
Sure. And stronger advocacy, stronger empowerment, relatives able to question, the complaint systems improving. Is that covered by legislation, or is it by regulation?
Regulation has improved, there's no question, not least of all because at the time of the Operation Jasmine police investigation, the regulators could only look at one home at a time. And yet this couple, this greedy couple, had a portfolio of about 20 odd homes. And not just one home was dreadful, several were dreadful. And so they could only focus on a single home. What happened was that health staff and social care staff couldn't bear to see these dreadful standards and contributed. So they rolled their sleeves up, got involved, started training staff. And of course, you know, the owners were delighted, even asked them to stay on, even though they were being, you know, I mean, it was a shocking scenario. And once they withdrew, of course, then standards slumped once again. But the regulator at the time could only deregister if standards were so poor. But of course, the involvement of external staffing improved standards. Will now cease.
I saw at one point the term, you know, too big to fail or not allowed to fail. And have you a view on that? Well, some services that you know, because it'll be a loss of a provider, that they're too big to fail. Is that something you've seen?
They failed in the end. 15 of their homes, you know, closed down, and they failed in the end. And yes, alternatives were found. It was not ideal, but they had become a monopoly, a greedy monopoly provider, and they had long since ceased to be attentive to their mandated purpose. And I think there's the point. We have to inspect and register to purpose, and their purpose was just set aside altogether.
And you mentioned there for profit and commercialization. Was that a big factor that you touched on it there, that the purpose was to make money and commercial benefit rather than meeting the needs of older people? Was that
absolutely
some of this? Yeah.
There was no question about that. I asked lawyers to look at the documentation concerning their companies, and they had several companies, and it was very clear that they were the sole directors and sole shareholders. There was no externality. There was no equivalent of a trustee saying, hang on a minute, do you really think it's a good idea to halve the food bill? And yes, indeed, that did happen in some of their homes. You know, do you really think it's a good idea to let supplies run down so much that our staff have to bring in toilet rolls from their own homes because they are so worried about the conditions in which older people are living in our homes? You know, those were some of the realities. And frankly, folk in Wales were tearing their hair out. How do you challenge such greed? And certainly when you know, the purchaser-provider split was introduced, there was no sense at the time that you would continue to pay people when they were offering a dangerous and even downright cruel service. Course, yeah. And yet that is what happened.
Yeah, yeah. it just sounds a litany of people being dehumanized. I think the coroner
completely
mentioned that, and I read some of the recent coroner findings, and it's quite. I know we've had our own shocking reviews and inquiries in Ireland as well, and it's something we're hopeful to learn from in future reforms. Can I ask you something about serious case reviews, and we might touch on a few that you've been involved with, but Winterbourne and Stephen Hoskins. But we had Jill Manthorpe over here in Ireland a couple of years ago, and Jill said to us that serious case reviews on their own won't affect change unless you see legislation, unless you see hearts and minds changing. She said that people need to actually change their behaviours and become assertive and illegal. That sometimes there's a view that the publication of a report is actually what follows from it. She said that. So I see you. Would you agree with that? That it's not just, sometimes people think the end is the report, but actually what follow through and what we implement, particularly the hearts and minds about how we change our behaviours.
That's right. I think a review is very good at collating information and contextualizing and setting out what's to be learned, because that's in English legislation and in Wales, in fact. The criteria has to be that you're going to learn lessons. I think it's more honest to say you will identify lessons. I can't claim that people have learned from this, but you can set out the lessons that have been identified, and you can hope that they will be learned. Interestingly, it is this week, it is 10 years since the broadcast about Winterbourne View, BBC broadcast, the Winterbourne View.
That's right, 2011, wasn't it?
Yeah. Exactly 10 years ago. And you think, well, surely that scandal, those awful images that we saw on our TVs 10 years ago, surely that will bring about change. Well, it did. It meant that a lot of politicians were horrified and expressed their abhorrence. So did the owners. So did the directors in the Cayman Islands and the rest of it. And what happened was that money was thrown at it. We'll have a transformation program. We're going to have 48 transformation groups. We're going to make sure that, people are transferred from these assessment and treatment units, by 2014. Here we are, 2021, and there are still 2,000 people in them. Why there? Because what is the case for discharging people from a for-profit service? You have to be full to make a profit.
And I think some of the echoes there for us in Ireland, we've had similar undercover investigative programs in nursing home in Lees Cross and our structure, well known in the public domain. And as we sit here today, we still don't have primary safeguarding legislation. Our assisted decision-making capacity act is still waiting commencement next year. So, real human rights legislation that I think sometimes an assumption. We've had the reports and we've put in place, and we have put in place measures. I sit in the National Safeguarding Office, and we brought in safeguarding teams, but real, not just the legislation, and it's actually about changing behavior and culture and organizational. Because when I looked over the Winterbourne report, and some things that struck me, so, the overuse of restraint, for example, and we still have, deprivation of liberty safeguards. We haven't fully enacted that here in Ireland yet, many years after our Stracta. What do you think are some of the challenges of making those changes when reports come out that the follow through, the implementation of meaningful change?
I think there's got to be with Winterbourne View, I made a mistake. I was very obliging to all the participating organisations, and I wanted them to contribute because it seemed to make sense to me. What's going to be a useful recommendation? I don't want to make recommendations that don't make sense to you. So I got some helpful information, but I overwhelmed people with all the recommendations. Why would you do that? Can I remember any of them? I can remember the ones that I thought was really important. One of those was there were 51 people in this home, in this hospital, Winterbourne View. Get it right for them. Make it possible for them to return to their homes, their communities, and have the sorts of lives that they want to have and their families want to support them to have. That seemed to me very manageable, but that got lost in a whole load of other recommendations. And suddenly over £10 million is spent on this transformation programme that has been, the impact of which has been negligible. So here we are 10 years later, and what now? Oh God.
Yeah. I did pick that up in I suppose what I saw in the your in search of accountability. You were very clear about accountability, and
yes.
in your, I suppose, review of Operation Jasmine, that you did hold to account state bodies, and you were fearless. I mean, the medical profession here in Ireland is very strong. Our prosecutory, our policing, they're institutions of state, and to call them out was very brave and strong, and I think that critical bit about the people's lives that were at the heart of this. So I also picked the piece about, you had numerous recommendations, and I suppose was a review that things would get better almost by when the government brought in the transforming care, that things was a review that things would follow.
Well, immediately, I mean, there were other reviews that took place. So the Department of Health's response was, we'll collate all the reviews. There was even the Equality and Human Rights Commission reviews. There were all sorts of reviews, and that tends to happen. And I think for me, the positive contrast with the Operation Jasmine is that it was commissioned by the First Minister. Yeah. That gave it a prestige that I didn't have with Winterbourne View. And also, I was a bit more mature. I thought, that nothing changed.
Yeah, no, I think it was a more what we call whole of government approach. You had the backing of the Welsh Assembly.
That's right. And so you think, well, what do I do? Well, I don't come out with hundreds of recommendations. I identify some manageable recommendations. And I had a really good minister who said, please just give us recommendations that we can actually work to, and we will work to, but make them real.
Yeah.
I talked to people about them, but I didn't say, and here's a pen, go and write them for me.
Right. No. Can I bring you to, I mean, a number of our audience today would be social workers, social care workers, nurses, who are working in field teams, in residential nursing home services. What can we do if, from your experiences about, you talked earlier about challenging management, challenging systems, challenging culture, challenging providers even, and I know that myself at times when asked to ask questions, and even challenging our colleagues. And you when you were here, you talked to us about the concerned curiosity and the vigilance that we as professionals need to bring. Would you say a little bit about that? Because I was very struck by that term, the skill of being of concerned curiosity, and how we bring that to effectively challenge, rather than being that kind of not the ineffective challenge. So let's say a little bit about that, Margaret.
Yes, I think when I think on the period in my life when my brother was unfortunately in a dreadful service, I visited with heart on sleeve, and I wanted to know clearly that he was all right, and it was very clear that he wasn't. He couldn't really set out what it was he didn't like, but I could tell he was scared. I could tell from his sweating that things that he was very stressed, and I could tell that he hadn't washed. So those are the sorts of things. It was a case of just using your senses. I also thought the place smelled, by the way, the whole place.
Yeah.
And it made me think that that knowledge comes of my, the fact that I've been brought up with this guy. And I think one of the blessings, and it is a blessing of care managers and social workers, is that you're very good, or rather you should be really good historians. You know what's important to people. You've contributed to assessing their needs. You've set out care planning. You have a strong advocacy role. You know things about a person, and that's quite separate from what it is that a commissioner's doing. You can advocate with and on behalf of somebody, and I think it's really significant that you're able, in that role, you can ask about how people are getting on. You know, how do they spend their days? Because we should expect a provider service, you know, to be legally and ethically operating, and we expect that service to be really well managed. So we can ask them, tell me about questions. You know, how is he spending his days?
Sure.
What did she do yesterday evening? Tell me about it. You know, what sort of resources do you bring into this service? Or, you know, it appears to me that they're struggling with swallowing. You know, what are you doing anything about that? And that's quite separate role. It's a gentle challenge role. But I think it's really a case of breaking through what can be an atmosphere of nonchalance at this level of tolerance. And organizations have lots of filtering mechanisms, including social care and healthcare. And, you know, not everything is a warning sign of dreadful things to come. But I think we've got to just use our antennae. I used to be, I used to be a researcher full time, and I was always staggered by how much people would tell me. And you know, I think a skill that's really important is actually just being, you know, being with somebody to let them tell you about something. Tell me about being a good historian.
That skill of being able to enable conversation and build rapport. I'm thinking of my own practice when I was a social worker, going out and visiting residential centres, both for children and older parents. That sense of, was there emotional warmth there between the people doing the care and the resident that I was visiting? And it was more than just the simple forms that you use to go out and fill, to prepare for the reviews or the upcoming case conference or decision. And I was really struck recently when, as you may know, all our systems are currently down here in the HSE. So in Ireland, we've gone back to paper and pen. But someone made, I think it was the CEO of our Child and Family Agency, Bernard Gloucester, said social workers have that strength of relationship, of talking, of rapport building, of building a strong communication with somebody. And as you say, asking the right questions, probing, allowing someone the space to talk. You know, forms and procedures are really, really important, but let's not lose sight of what should be our core skills. And so you feel those are really important to the work we do.
Absolutely, because, you know, how else do we understand, you know, the gap between aspirational policies and reality? You know, one of the social workers, for example, who visited one of the dreadful homes in Operation Jasmine inquiry, sat in the office and did the review in the office with the manager and then went home. So the story was a shocking way of operating and really quite remote from that which is the centre of social work, which is about relationships, as you say.
Yeah. And just on one or two final areas, where somebody, and we've seen it through whistleblowers, we've seen people who've made protected disclosures here in Ireland, that ability to challenge and question, particularly in cultures that might always welcome it. And, you know, have you any kind of advice around, you know, how one can assertively challenge and question?
Well, I think it's certainly something that is easier as you get older. I've certainly found it easier as I've got older. And it's not something we're taught at school, but I think it's really important that we remain respectful, isn't it? I recall with enormous gratitude a woman called Alison Price, who I met many years after she'd left South Wales's inspectorate. But she had visited the homes that were operated, that were scrutinised by the police under Operation Jasmine. She was appalled at what she saw. She was a nurse by training. She was appalled at what she saw, and she called into these homes regularly. They were spot checks, and she said it was on my way home so I could call in. She was tenacious, and she very quickly gathered that this this particular owner used to scream abuse at her. And she said, you know, he was almost nose to nose to me, yelling at me. And I thought, you are a really difficult man to work with, and I'm not fazed by you.
Right.
And I like to think that, you know, many of us could handle that, but she did handle it. She said it was awful at the time. It was awful. I look back, and I'm angry when I look back because I did what I could. And I think that's what we have to do. We have to make things right as often as we can, and think, well, who am I doing this for? You know, is it for my job satisfaction, or am I extremely concerned about this person for whom I have principal responsibility? So it is about challenge. It's also about seeing our place. You know, those of us who are interested in adult safeguarding, we've got to remember that we work in a very complicated system. You know, if you are concerned about, you know, a home, well, who is the provider? Are they operating ethically, and is it a well-managed home? You know, where is the care manager with, you know, responsibility for needs assessment and care planning, and is that happening? And what about the commissioner? You know, is the commissioner someone who's making these fleeting decisions, and the consequences are, you know, they're spared the consequences of their decision making? You know, and then we talk about learning lessons, and actually it's in the quality assurance that safeguarding sits. It's not in those other bits of the system. So, you know, safeguarding can't impact on all those, but where we can impact, we can and we should, because it's so important that we make things right for people as often as we can.
Thanks, Margaret. One final area, Margaret, and I bring you back to Stevens Hoskins serious case review, and I suppose it's more on the community side of agencies working together, and you know, we've a long way to go here with health and justice and all the various parties working effectively, sharing information. Have things worked better, improved, more effective sharing of information? We you know, for people who are living in kind of vulnerable situations or on the margins, as Stephen was. Do you think things have the various you know, programs and legislative, has there been a change in the UK of agencies working more effectively together?
I think certainly in Cornwall, where poor Stephen lived, I think certainly in the period after his murder, there was an enormous effort made. I think the shock waves were so considerable that was sought by all the agencies concerned. And now that clearly was a long time ago, and it was pre-COVID. And I think one of the things that troubles me now about the pandemic you know, where are they now? Where are the Stephens now? Are they, you know, are they exposed to people who would wish harm on them, or wish to see them as, you know, an income source? We know that people are more at risk, and we know that scammers are very adept at targeting people. And Stephen was conspicuous in terms of his appearance, and he was at risk for that reason. So pre-COVID, I'd like to think that there was some very positive development. I truly don't know.
I think COVID has caused a real challenge around people who are on the margins, or may not be, I suppose, actively engaging with the support services, because with social isolation and restrictions, it is something that's of quite a concern. And we've seen the growth of mate crime and online abuse and scammers. Certainly here in Ireland, it's grown exponentially during the COVID period. Margaret, you've been very good. You've raised a huge amount of awareness, I think, today, covered and shared a lot of your experiences. I think there's a lot of thought there that how we can make a difference. I suppose any of us listening today who are social workers, nurses, social care workers, healthcare workers, what can I do in my practice? What can I do as an individual? What can I do when I walk into work tomorrow to make and change and be more confident in my work, and recognize this is a human rights issue. This is something around people's right and entitlement to the same health, the same life, the same lifestyle, the same income as everyone else. And you know, we were chatting before we came online that COVID has made that even more difficult for older people. So I'd like to thank you on behalf of the National Safeguarding Office to contribute for our World Elder Abuse Awareness Day. Hope we'll have further events in the future, and maybe look forward to seeing you in person when travel restrictions are eased, and we can get back to having face-to-face conferences and educational trips. So thank you very much, Margaret, and good luck in all your work. Thank you.
Thank you, Tim.